Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from OTSCA.
This program is presented by Medscape Education Global.
Hello and welcome to this programme on optimising outcomes for patients with IgA nephropathy. We're going to look at novel B-cell targeted therapies and the changing treatment paradigm. So I'm Smita Sinha, I'm a nephrologist from Manchester in the UK. I'm very much a clinician and I run a combined clinical and research glomerulonephritis service. Our catchment population is large, it's around 1.6 million, and we've participated in numerous GN trials. I'm really looking forward to this programme because I hope it's going to tell me how to treat my patients now that we have all this trial data. Warm welcome to Dr. Jürgen, and Dr. Sydney Tang. I'm excited to have you both here. You've done so much work in the area, but I'll let you introduce yourselves and your connection to the topic today.
Yeah, so my name is Jürgen Flöger. I'm from the University of Aachen in Germany. I have a long-standing interest in IgA nephropathy. My first paper actually is 1991. I led the German Stop IgAN trial, which showed that steroids, at least in a Caucasian population, have no long-term benefit at all. And I do coordinate the worldwide KDIGO guidelines, which just came out in the updated form for IgA nephropathy a few days ago.
And I'm Sydney Tang from the University of Hong Kong. I also have a long-term interest in IgA nephropathy, and I have reported some effects of MMF, at least in Chinese patients. I also participate in IgA nephropathy trials, including being the national lead for the PROTAC trial on sparsentan and some other trials. I'm also on the IgA nephropathy work group of the KDIGO guidelines that Jürgen coordinates.
So thank you both. So we're going to begin with a real-world case that illustrates both the challenges in the care of patients living with IgA nephropathy, but also the exciting potential of new treatments. So this is a patient who presented a decade ago in a road traffic accident, and he had hematuria, which was initially attributed to the road traffic accident, but actually it was an incidental finding, and that's how his IgA was detected. He was slightly larger, non-smoker, but he had hematuria and he had proteinuria at presentation, had a biopsy. But this is what's happened to him over the course of, well, now 10 years. And you can see we tried a number of treatments. We tried steroids and MMF. These were the things that we hoped would work. Some of them reduced proteinuria, but the key message is a sustained decline in EGFR. And his EGFR is now approaching 15. And despite all our attempts, this is where he's at. I'm now going to hand over to Jürgen, who's hopefully going to tell us how guidelines have changed, or how, perhaps what opportunities guidelines give us that my patient didn't have.
So thank you, Smita, and I will tell you what the latest KDIGO IgA guideline tell us, but also what they not tell us. And I'm really afraid there's many things we're not told, so it still takes a good physician to treat these patients. So let's start out with patient stratification. We have a practice point in the guidelines saying that clinical and histological data at the time of kidney biopsies can be used for risk stratification. That's not new, and we continue to recommend the usage of the International IgAN Prediction Tool to assess the risk of progression and to inform shared decision-making with patients. The MES score was a landmark advancement in the scoring of the kidney biopsy in IgA cases. This was developed worldwide among a huge group of nephropathologists and is definitely the best we have today. Having said that, you have to realize that the MES-C score is still subjective. You assign a score, and of course there are no fixed cutoffs. It's a subjective assessment. And what this study showed is that if you compare your local nephropathologist with the Oxford nephropathologist, The good news is in most cases they are in agreement. And in fact, that is particularly true for tubulointerstitial lesions, which of course make up most of the biopsy core, so they are relatively good to judge. The somewhat scary news is that the more inflammatory lesions, the M, the E, and the crescent score, they really are inconsistent, and every fourth or every third lesion is not seen in Oxford. And I'm a little worried that if we see a crescent which cannot be reproduced in Oxford, we should probably not use that to make therapeutic decisions. In terms of prognosis, yes, that's fine. Prognosis is relative. But to decide based on this what to treat with is a little scary. And in fact, we do recommend in the guidelines that the prediction tool should not be used to decide on a specific treatment regimen. And we have no clinical studies to show that prospectively randomized to a particular treatment regimen based on MES-C scores. We have a different opinion there compared to the pediatricians. If you look at the latest IBNA guideline on children with IgA nephropathy in 2025, you can see that there's a central role for the MES-C score in that guideline. And then the decision is, do you give RAS blockers and/or steroids? Because that is all what pediatricians have. It's a nightmare. It's where we were like 5 to 10 years ago. But clearly, there's inconsistency here, and much more work needs to be done. And emerging work says that, for example, if you do a sophisticated morphometric analysis of the biopsy core, you can have a much more precise and much more objective and reproducible measurement, and new parameters are evolving. Talking of the IgA prediction tool, which is freely available, this is again something we need to be a little bit cautious with. It is clearly the best we have, but you have to realize it's based on historical cohorts, and we're seeing very rapid changes in the landscape of how we treat IgA nephropathy. So this is a study out of Beijing, and if you look at the middle panel and compare the predicted risk with what was observed, you see that it's no longer on the line of identity. And similarly, we even have to ask, is the MES-C score still valid with today's cohorts, where possibly many patients, if not the majority, are on SGLT2 inhibitors. There's more consistent usage of RAS blockade, at least I hope, and we have new drugs. So again, a little caveat here. The guideline says that the treatment goal changes. In the past, we had said lower proteinuria to 1 gram or less per day because we considered that safe. That is no longer correct. And the guideline now says, in terms of what is my therapeutic aim, we should lower eGFR loss to less than 1 ml per minute per year for most adults. And here comes the bad thing: for the rest of the patient's life. And you've just seen Smita's case, where initially everything looked okay, but as you follow that patient for 10 years, for 20 years, it's no longer okay. And the only validated early biomarker is urine protein excretion, and the new target is to lower that to less than 0.5 gram per day, ideally 0.3, so something we would call full remission. We have learned from the British RADAR cohort, the Rare Kidney Disease Registry, that even low grades of proteinuria predict bad outcomes. And that is an important new insight, as opposed to the past where, as I said, we had a threshold of 1 gram per day. If you focus on the blue line on top, these are patients with a UPCR between 0 and 0.8 grams per gram. And you can clearly see that the survival free of kidney failure is getting less and less and less with time. And please consider the x-axis here. It's 15 years. Yes, There are few patients out there, but it's a fairly linear decline. Now, the IgA prediction tool covers about 6 years, 18 months from the biopsy. And I'm using that to illustrate our relative inability to really predict. We need longer-term tools. If you have a patient with, let's say, a proteinuria of 0.8 grams per day, you would tell that patient, hey, your risk for kidney failure in the next 6 years is something like 10%. He or she would be worried, but not overly worried. If you tell that same patient, hey, your risk is 50% to end up on dialysis in the next 15 years, they're deeply worried. And they will do whatever you tell them just to protect their kidneys. So very clearly we need to work on long-term prediction tools and get away from really short-term observation periods. But is progression really that fast? Well, we have, again, diverging data. This is the 421 subgroup of IgAN patients in the German GCKD cohort. These are 5,000 patients in total, which we've now followed for 11 years in a purely observational fashion. So they're being treated by local nephrologists, and we just follow these patients and see what happens. We looked at albuminuria, and the good news first is, yes, we confirm that even low grades of albuminuria are associated with an increased eGFR loss, and you can roughly translate that into UPCR. So that's confirmed. But you see that progression in Germany is much less than it is in RADAR. So maybe, Smita, you should send all your patients to Germany and have them live there. It's something good there. And if you look at the patients who would be typically included in a clinical trial, it is those in the red box. And you see that they have a really slow progression rate in the hands of my German colleagues. And if you then look at all the recent trials and focus on the control arm, every patient, every trial required you an optimized RAS blockade, supportive care, whatever. And then you added either placebo or a RAS block on top, you see this incredible range of GFR losses per year, ranging from minus 1.5 in our German Stop IgAN trial, which ironically is exactly where the non-interventional cohort is, to up to 15 mils, so a tenfold difference even in the control arms, making me a little worried that maybe supportive care, RAS blockade lifestyle is not used to the full extent in some instances. And what the guidelines also don't tell us, and no cohort has included these patients, are really early IgA patients, and they would completely mess up any predictive score. This is one of those studies from Bergen in Norway, where they took kidney biopsies from patients who we would normally not biopsy, essentially no proteinuria, normal GFR, just microhematuria. If you then discover IgA nephropathy, and you follow these patients for 20 to 25 years, a third will lose the IgA nephropathy, spontaneous resolution. 50% have some persistent glomerular injury but preserve GFR, 20% progress, 5% really progress. And at least in that study, it was completely impossible to predict who would progress really to a bad stage. There are some very, very interesting data that there may be molecular markers, but that of course needs to be confirmed. It's a smallish study. But the take home is, if you ever capture a patient very early, it's extremely difficult to predict whether that patient will progress. And the best you can do to that patient is make sure you see them again in a year, in 2 years, in 3 years, in 10 years. Don't lose them.
Thank you, Jürgen. So that was, as always, a tour de force. So Sydney, over to you.
Well, I think Jürgen gave a very important overview of the current status of IgAN treatment. If I rewind back to 4 years ago in 2021, this was what the guideline looked like, and you would see that the consideration for recruiting patients into a clinical trial is high up on the algorithm, meaning that in those days we didn't really have approved a therapy for IgA nephropathy. What's more, I think in 2021, the KDIGO guideline has not yet recommended patients with IgA nephropathy be treated with an SGLT2 inhibitor if they did not have diabetes. Well, as we heard, the 2025 guideline has just come out. It's an update. It has made a significant shift in the treatment of IgA nephropathy. We have moved away from just including patients in clinical trials and distilling some patients down to corticosteroid treatment to a form of paradigm in which patients could be treated in both directions. Number one, to treat the drivers of IgA nephropathy, and secondly, of course, to treat the CKD component of IgA nephropathy, because we realize that every patient who is diagnosed to have IgA nephropathy would have variable degrees of CKD, and therefore CKD management is also an important aspect of management. So this new strategy would prioritize the concurrent use of not just RASI, but also the use of SGLT2 inhibitor upfront in order to improve long-term outcomes. Included in the guideline is also the use of sparsentan or DIRA as a dual endothelin and angiotensin receptor antagonist, which will, as we know from the PROTECT study, reduce proteinuria and preserve eGFR on a long-term basis. And it's also an approved therapy for IgA nephropathy. And also in the new guideline, we also have on the other limb of the treatment algorithm, a therapy that would actually target the drivers of IgA nephropathy, meaning the formation of Gd-IgA1 and immune complexes containing anti-Gd-IgA1 IgG mostly, but also IgA. And I think currently the only approved therapy for reducing Gd-IgA1 in IgA nephropathy patient would be Nefecon or the targeted release budesonide, which has been shown in the NefIgArd trial to really reduce the progression of nephropathy in terms of eGFR loss and also reduction of proteinuria. So this is the most updated treatment algorithm in which we clearly see that is different from the 2021 algorithm. It is clearly divided into two limbs, one focusing on reducing the immunologic drivers of IgA nephropathy and the other targeting the more generic inflammatory component or the CKD component of the disease, including lifestyle modification, that is very important, including also the background therapy with RAS inhibitors, possibly also SGLT2 inhibitor, and the use of the DIRA. So there is a recommendation that we would want patients at risk of progressive loss of kidney function be treated with sparsentan. But there is actually also a caveat because sparsentan is actually not readily available in many parts of the world, definitely not in many parts of Asia. So this is something that we need to bear in mind. And then, of course, on the other side, you would see the use of Nefecon that I've just mentioned. Systemic corticosteroid comes with a lot of side effects. We learned from testing trial that it could actually provide benefit, but it comes with a price. There are also ethnicity or race-specific treatment, for example, MMF and hydroxychloroquine, mainly used for Chinese patients. Tonsillectomy, mainly used in Japan and not anywhere else. So I think this is the current status of the treatment algorithm for IgA nephropathy. So talking about emerging therapy, there are quite a number of B-cell modulators coming along. They have not yet been included in the guideline, but I think we also need longer-term data, eGFR data, for them to be considered for inclusion into any treatment guideline. So roughly, we have the APRIL inhibitors, including sibeprenlimab and osigarkibab, that have been shown to reduce proteinuria and stabilize eGFR. There is also the APRIL-BAFF inhibitors, including atacicept, povetacicept, and also telitacicept, and they also have good data that shows that they could reduce GFR and also greatly reduce the slope of eGFR in addition to stabilizing proteinuria. And last but not least, of course, there is the plasma cell or the anti-CD38 agents, including the two shown here. And I think the trials are actually underway, so we need time to actually observe data that could actually provide evidence for the efficacy in IgA nephropathy. And then the other big group of therapy would be the complement inhibitors, because we know that the alternative pathway, at least, is activated in most patients with IgA nephropathy. And we have these trials included here: factor B inhibitors, iptacopan, for example, which has already been approved for IgA nephropathy. There are other agents coming along. There is also the C5 inhibitor study ongoing using revolizumab to look at the effect of this agent on eGFR and also albuminuria. So I think this is so far the upcoming treatment that could be considered for inclusion in the guideline when we have the results ready.
So gosh, Sydney, that's quite a lot, and I think it's fair to say that our treatment's goals are evolving. So where are we now? And you've talked about the drugs that are coming, but how do we use them? Are we going to use them both at the same time?
Well, I think this is kind of a $6 million question, because we don't have data, we don't have trial data at least, to tell us whether we should use them sequentially, or we should add one on the other rapidly, or in a more sequential manner. So we don't have those data. But I think from the physician's point of view, we always focus on eGFR, slope of eGFR decline, proteinuria, albuminuria, etc. But I think it's also important to consider from the patient's perspective that what they consider to be important. And this is a recent real-world survey of 1,500 patients with IgA nephropathy, and you would see that they really worry about pain. They also worry about fatigue, and most importantly, quality of life that the disease brings to them, rather than the parameters that we focus on. But of course, those parameters would also be parameters they also look at. So I think it's important to take all these into consideration, discuss with the patient, and I think it will be the era in which we have co-management. I don't want to impose, single, double, triple therapy simultaneously, sequentially on the patient, but I think it's really through a discussion with the patient, taking symptoms into account. I think it's also good that compared with 4 or 5 years ago, when we don't have any treatment, now we are coming from despair to promise, because I think we are coming to an era in which we have the emergence of novel therapy, and I would anticipate perhaps that the guideline would need to be continuously updated as we have new data, new agents, and new class of agents coming along for the treatment of IgA nephropathy. For example, I think the sibeprenlimab trial has shown us that the rate of eGFR decline can be, at least within the period of the study, reduced to rates not more than physiologic decline. And I think looking ahead, maybe we should think about a therapy that could stabilize eGFR on top of all the other parameters, because ultimately we want to stabilize eGFR, prevent nephron loss, and from the patient's perspective, they do not want to go into kidney replacement therapy or dialysis. So therefore, if we have a therapy that can stabilize eGFR, reduce the rate of eGFR attrition to no more than physiologic decline, then we have to start thinking about, if we have such agent, whether or not we will still need all the other background therapy, RASi, sparsentan, and so on. So that's something that we might want to think about. And this is not just restricted to sibeprenlimab. We also saw in this study that was published last year that there is another ERA, endothelin receptor antagonist. This is SC0062, which also within the study period was able to reduce eGFR loss to less than 1 ml per minute per year. So I think this may be good news for our patients, but I think we need more time, we need long-term data to see if they can achieve such a low rate of eGFR attrition.
Thank you, Sydney. So there's a lot to take in there. A lot has changed over the last 5 years. So I'm going to ask you both these questions now, with hopefully similar perspectives, but in your patients, what are you going to start first? You've got the biopsy. What are you going to do? And what's going to influence that decision? So Sydney first.
Well, I think the answer from me is actually very simple, because despite all these trial results, despite the guideline, many of these new agents are actually not available in my part of the world. So we're still using nothing more than RASI, SGLT2 inhibitor. As I said, Chinese patients, we can consider using MMF plus a little bit of steroid, maybe a reduced dose corticosteroid. But apart from that, we don't have Nefecon, we don't have sparsentan. So the answer is quite simple for me. I'd like to hear from Jürgen.
Yeah, so whenever I talk about the new guideline, the first question I get is, do I really have to start simultaneously? And that will be an ongoing discussion for quite a while. Obviously, not all patients need it. Obviously, that this will add cost. But obviously, it makes a lot of sense. If I were a patient, I want to have maximum treatment and arrest my disease where it is, rather than, just like your patient, slowly losing one nephron after another. So it's a dilemma we're in now. The good news is that most of the new treatments are very safe. And that has kept me from, or kept most of us from, using steroids right away. The bad news is they're costly and they really add up. So what we really need is better prognostic tools, new parameters to decide whether there are particular subgroups of patients. How much can the biopsy guide me? I think that's an unresolved issue, but a very logical question. And people are working on that, and we do get fascinating data. My nephropathologist, Peter Bohr, just did a study where retrospectively they looked at patients receiving steroids, and the take-home of that is that with new parameters, they can determine that 70% of the patients received steroids for no good. 30% had a benefit. If we have such tools, then maybe this question is easy to answer. Right now, no good answer to that. If it were me, started both.
Yeah, I guess we're moving towards that precision medicine. We've got the tools, we're just not quite sure when to apply them. I think one of the things that stood out for me in the guidelines is that real push to treatment initiation early, whereas historically we've talked about getting people on maintenance treatments, optimising RASI. What are your views on early initiation of something, Sydney?
Well, I think in my view, if a patient is diagnosed with IgA nephropathy and we know from the 4-hit hypothesis that the disease is going to progress, patients can lose nephron slowly, moderately, or rapidly. But even with the available tools, sometimes we cannot predict. So I think it is important that these patients should, of course, embark on what we call supportive therapy. But I think in addition, I think at least these patients, depending on their blood pressure and the proteinuria level and so on, that these patients should be treated with a RASI plus or minus an SGLT2 inhibitor. I'm not trying to say that every patient should be treated with an SGLT2 inhibitor, but I think maybe a substantial proportion of them should receive it for the potential benefit. So I think we have come to a time when we should actually actively or proactively treat our patients rather than sitting on them and wait and see if the proteinuria does not progress or eGFR does not decline. I think we have to take a more proactive approach just to achieve some of the treatment goals in terms of blood pressure, in terms of proteinuria. We want the proteinuria to be down to less than 0.5, preferably less than 0.3, and ideally I think none.
Yes, the 0.5 is an interesting number, isn't it, that's featured and generated a lot of discussion. We know that with some of the therapies like sparsentan in the PROTECT study, a proportion of people did get below that threshold. Now, where do we sit with the sequential addition of a disease-modifying agent versus just sparsentan alone, if that could potentially get you below? What would you say to your patient, Jürgen?
I mean, for me, this is a super practical issue. Because in Europe, these new treatments are all approved if proteinuria is above 1 gram per day. So let's say I have a patient on a RAS blocker with a proteinuria of 1.5, I switch to sparsentan. The likelihood is that 2 weeks later, that patient has a proteinuria of 0.7, 0.6. So that is better, but that's not the full remission I want. And from a very pragmatic point of view, that would be a reason to start, let's say, Nefecon or in the future B-cell modulators right away in parallel. And conceptually, I think that makes sense. Go to a hit hard and early policy, preserve every nephron you can, and then rather taper your treatment and step down than slowly building up and losing nephrons on the way.
So yes, what we're hearing is that we need to start initiating early, and we may not have all the tools we'll have in the future, but we need to start getting our mindset ready for those options so that we can have those conversations with our patients and then choose the treatments that will work for patients as well as clinicians. So thank you for a wonderful session. I always learn lots, and I always learn practical tips, I think, which is particularly helpful when we have to go back and face our patients. But I would ask you to give me your final comments and thoughts now that these new guidelines are out, and hopefully also give us a view on what you think lies ahead.
Hit hard and early. I think that makes sense conceptually, even though it's costly, but dialysis is even more costly. And we have to learn how long to treat, how to treat, maybe in the future switch to something like an initiation, induction therapy, and then maintenance, as we have used in ANCA vasculitis, lupus, and whatever, because it's simply very unlikely that after 2 years of therapy, the IgA nephropathy will have disappeared.
And I would add that perhaps we need to diagnose our patients early. We're no longer in the area in which we can wait and see. I think we should biopsy our patients much earlier at much lower levels of proteinuria. And even if the patient has just got a little bit of proteinuria with microhematuria, I think these patients should be biopsied. And if they are biopsied and they get diagnosed, they should be initiated on some form of treatment, hopefully to halt the progression of disease. And depending on availability of agents, we might want to initiate the appropriate and available therapy according to your locality.
Thank you, Sydney. Thank you, Jürgen. I think that was a fantastic session, and particularly the end highlights what we need to do, which is diagnose early. That means get that biopsy done, make the diagnosis, and then treat them. And I think, as Jürgen said, treat them hard at the beginning, save those nephrons. And thank you for participating in this activity. We've got some questions to follow. Do complete those, and importantly, complete the evaluation. It helps us make future sessions useful for you. Thank you.
This program was presented by Medscape Education Global.